Good afternoon, everyone. I'm Barbara Fain. I'm the Executive Director of the Betsy Lehman Center for Patient Safety. Just really want to welcome all of you to our fall PFAC forum. I am going to keep my remarks really brief because we have a really full, what I know is going to be a terrific program for you. And we're also we want to make it a little bit interactive and leave time for your questions and thoughts. As always, I want to thank I'll thank in advance the presenters from 3 hospitals that you're going to be hearing from, and they will be introduced separately as the program proceeds. As always, I want to thank members of my team for all the work in pulling this together. And finally, thank all of you for taking your time to join us for what, as I said, is going to be a really it's going to be a great sharing of information and conversation. Why is the Betsy Lehman Center even involved in this aspect of the work, and why have we thrown some of our resources behind PFAC development? And just in a nutshell, we really see PFACs as the key to any kind of meaningful patient engagement. And everyone talks about the importance of patient engagement, but talking about it and doing it are really two different things. And it's not easy to do. Otherwise more would be doing it. And we also in turn see PFACs as really the key to progress and really engaging patients and families around safety improvement. And we know that there's a bigger role for PFACs than most have been playing. And but today, what we're going to be doing is inviting 3 hospital representatives from 3 hospital PFACs to talk about how that is playing out in their institutions. Without further ado, let me turn this over to Jackie Afranie from our team, who has a quick interactive survey for you just to get things started. Jackie?
Thanks, Barbara. Hello, everyone. We would have loved to do introductions, but since we're a large group, we can't, but we still want to know who's in the room. I'm going to run a quick poll just to get a sense of who's in the room. So you can answer the first question if you're a hospital representative or you're a patient and family PFAC member. And then the next question is about your fall preferences, hayride or corn maze. So let's give that a minute or so. This is great. We can see that, we have a good representative, about half the people in the room are for a hospital representative, and, about a little more than a quarter are PFAC patient and family members. And hayride for the win. It's nice to see. Thank you all for participating. At this time, we're going to get started with our first presentation. So I'm going to have, if the presenters can sort of get ready to share their screen. And why they do that, I'm just going to introduce them. So we have first up presenting from Southcoast Health is Lindsay Dowd, who is the clinical practice manager at Southcoast Physicians Group. And we have Yinka Oluwole, who is the executive director of service excellence and patients experience at Southcoast Health. And we're excited to hear what they have to say this afternoon.
Hello, good afternoon, everyone. My name is Yinka. Hopefully you can see my slides. Yes?
Yes, thank you.
I'm so used to Teams now, so I was a little worried there. And so we are presenting, myself and Lindsay are presenting today on behalf of our PFAC here at Southcoast Health. One of our PFAC members would have initially done it. Unfortunately, she's not available today. So Southcoast Health is located in the southeast Massachusetts. This area is known as the South Coast. We are from Providence to Hyannis, as you can see on this map. It's made up of 3 hospitals that initially merged in 1996 to create what we now know as Southcoast. We are the largest employer in this region. We employ over 7,500 people within Southcoast. So of those 3 hospitals, you can see here, we have about 787 beds. We also have 76 clinics across the region, which employs over 675 physicians. On here, we didn't mention our urgent care. We do have 7 urgent cares. 1 additional will be added to that collection soon. Again, and we have over 3,000 births yearly, over 30,000 inpatient discharges. So that is us here at Southcoast. Our PFAC. Our PFAC is made up of 17 PFAC community advisors as well as 18 staff members. So currently, we have 16 ongoing projects and initiatives that our PFAC members are engaged in. In addition to that, every single year, we do start off first by setting certain goals. And so each PFAC member is asked to find a project that they would like to engage in each quarter. Several of our PFAC members do engage in more than 1 project. We have some members who are on at least 4 or 5 projects that they engage in ongoing. So the picture that we put here is Mary Lou, who is part of the project we're going to be talking about today. So here at Southcoast, we have a robust application and interview process that ensures that we select the best candidates. In addition to that, one of the things that we do is when we identify a project that we would like to engage our PFAC in, sometimes I do share this project or initiative with the entire PFAC body, but there are times where I might just reach out to a select few advisors depending on their interests. We just started to do something, we just implemented one-to-ones with our PFAC members where they actually get to meet with our subject matter experts within our healthcare system to discuss projects or initiatives that they might be interested in. And these projects, when they do come up, those are the members that we tend to reach out to. In addition to that, when I do put out a project, I may also look at their time availability because we do have some members who are full-time and then we do have some members who are retired and have a little bit more time flexibility. We also look at experience and their insights. We have some PFAC members who have clinical backgrounds, so those people might go for certain projects like in quality or safety, or things that are set in the ED. And we might also go for people who, who have a commitment or a passion about a specific topic. And so those people I might reach out for certain things. But I also try to also make sure that there's diversity of thought on all of our projects as well. And this is a picture of some of our PFAC members at our volunteer event that we had recently. And I will hand off to Lindsay, and she's going to share on our Southcoast Cares About My Diabetes project.
Everyone, I don't know about you, but I did the hayride, so I guess I was with the rest of the group today, so that's a good thing. So I'm introducing Southcoast Cares About My Diabetes, which was a grant program. We were awarded $1.7 million by Blue Cross of Mass and the Institute of Healthcare Improvement with the goal of addressing disparities in diabetes care for the Hispanic, Latino, Black, and African American community members. The actual project was January to June, year and a half, a very lengthy project, but it involved a lot of different aspects. The project team was a variety of disciplines, which included community health workers, nurses, pharmacists, primary care, endocrinology, and of course, our PFAC member. We had community partnerships with the Boys and Girls Club and the YMCA of Southcoast. And our aim, again, was to reduce the disparities in diabetes management and outcomes for our most at-risk population. And the goal was to provide a holistic approach to diabetes management and then improve culturally competent race, ethnicity, and language, the real data in our EMR called EPIC. How we did this is we hosted multilingual groups and we made sure that our materials were multilingual as well. And we actually worked with an outside vendor with our materials because more often than not, you will find materials in both English and Spanish, but when you look for a third language, and ours happened to be, we had a need for Portuguese based on our community, it was very difficult to find that information. So we actually worked with the vendor who created our materials in English and Spanish, And we took his materials and we then translated them into Portuguese for him. So then we were able to utilize those materials for our population. Our interventions included home visits, one-on-one support with not only either a pharmacist or a pharmacy tech, but also a community health worker. And those home visits and that one-on-one support really provided us with the information that we really needed to be able to assist those patients 100% with what they needed. We also created a digital platform, which is an educational platform via MyChart, which is via Epic. And that's a lot of educational care plans, approximately 21 care plans, a check sheet for patients, as well as short video snippets all about diabetes, very, the multiple aspects of diabetes. We held community events. We did our groups at the Boys and Girls Club in New Bedford because we felt it was important to be in the patient's backyard, in their neighborhood, in a place where they felt comfortable and safe to learn. We were at the Solanas Food Pantry twice a month. We attended the Cape Verde Festival. We did Boo at the Buttonwood Park Zoo and the Podkawa 5K. So we were at all of these events, providing materials, speaking with patients and recruiting patients in order to participate in our group. We did outreach to 805 patients. And by outreach, we mailed out postcards with information on what we were doing and informing patients that they would be getting a follow-up call. The reason to do that is to get them prepared for that phone call so that when we actually did do that outreach call, they were prepared. Oh, right, I received something in the mail a few weeks ago. Yep, I understand. I was waiting for your call, etc. Much better than a cold call. We had 146 patients participate in groups. And then we had one engaged in other aspects, and that was actually our PFAC member. And when I say engaged in groups, participated in groups, full participation in groups. It wasn't just attending one group. We held 4 groups and most patients did at least 3 of those groups. At the end of the groups, we had a reunion and we ended up with approximately 85 patients in that group out of 146 at that reunion. So, it was well loved by the patients. The results so far of our efforts, we've seen an overall trend of the increase in percentage of patients with an A1C. What we're saying in control, because the patients that we outreach to had A1Cs of 9 or above. For those of you who aren't familiar with what an A1C is, it's a glycosylated hemoglobin, and it is a 3-month average of a patient's blood sugar. So when you have diabetes, you will get that every 3 to 6 months as a way for your provider to take a look to see where your blood sugars have been. So as you can see, both pre and post, when we look at the population and we look at A1C in control, you can see a definite uptick with the post. And we're very proud of that. Next slide. Thank you, Mika. So the PFAC effect, this is what we're all here for today. And the PFAC effect was driven by Mary Lou Francis. She was our PFAC member, and she not only was a PFAC member, but she also is has personal experience with diabetes, which she said was okay to share. So not only was she a PFAC member, but she was someone who lived and breathed the diagnosis that we were trying to support and educate patients with. And it was just, it was a win-win. She provided ongoing feedback to the team. She actively participated in work group meetings. She was constantly giving feedback to us. And it was, well-revered feedback. She helped us review our educational tools and our materials. She'd provide updates regarding questions or trends in the patient community, and specific to monitoring technology. She could come in with her own feedback and then that of having spoken to patients as well. She advocated for the mental health aspect of diabetes. Now, we look at diabetes and we say there are 4 pillars. It's diet, exercise, meds, and monitoring, but it goes so much more than that. So we had a real focus on the mental health aspect, as well as, what to do when you're traveling, pregnancy, intimacy, sick days. I mean, it's just, having a chronic illness is overwhelming. And what we tried to do with the help of Mary Lou was make it very easy to understand for our patients. And then Mary Lou also provided monthly updates to the PFAC team. And then based on her efforts, we were actually awarded a Southcoast Health President's Team Award. Next slide, please. So the challenges and lessons learned, I think that there were more lessons learned, and that having that PFAC member participate was a huge win-win for the group. You know, she was very committed to the project, and it actually made us have a consistent patient focus. You know, a lot of times if you get healthcare folks in a room, you know, they're talking about a diagnosis, they're talking what to do about it. And, you know, we don't have that patient focus necessarily. We think we do, but having that PFAC member there all the time really made us have that consistent patient focus. As far as sustaining engagement, we're going to work with Mary Lou to have an ongoing review of any updates based on our successes and any ongoing feedback that she may have for us. Next slide.
So thank you again, Lindsay. So as we continue to plan our PFAC, I guess for FY25, which started this month, one of the things that we're doing is we're looking to continue to expand the involvement of our PFAC on various initiatives and projects across the system. And I'm sure many of you who are on this call are probably aware that there's not always that awareness of what the PFAC role is within a health system. So we want to continue to increase that awareness across the system. Quite recently, we actually had a volunteer open house where we had our PFAC members, our volunteers, and a few others come together and just kind of educate not just our health system, but also people in the community. So that is something that we're continue to work on, increasing awareness. And in addition, we want to use the PFAC to continue to drive our Southcoast values and what we have come to know as our Southcoast Way, which is our service excellence training program. So quite recently, we actually, like I said, we had our volunteer open house, and one of the candidates who actually came to that open house actually shared this quote, and I love to share it. And she goes, as a PFAC member, she wants to make sure she ensures that all healthcare workers know that it's also that extra hello, that smile that makes a difference to a patient. So it's not just the care, it's so much more. So thank you very much for having us this afternoon, or here we go. And I guess we are ready for any questions if there are any.
You know, I have one question for you just to start off. I think a lot of us think of PFAC work as being very associated with a single hospital, and Southcoast, with this project, really integrated PFAC across the healthcare throughout the health system. And just wondering if you've encountered any challenges in sort of moving PFAC work out of the confines of a specific hospital and more system-wide.
I would say it's just ongoing awareness. So it's just really making sure people know that the PFAC is an available resource. So other than that, I think that's one of the challenges we have with the across the 3 hospitals, as well as our physician practices, is just letting people know that this resource exists and how best to engage with them.
Mm-hmm. Okay, great. So a couple of questions about the makeup of your PFAC. One is how many people in the PFAC? Is there one PFAC for all 3 hospitals? And who did the, yeah, go ahead.
Yeah, so yes, it is one PFAC for all the 3 hospitals, as well as our physician practices. We also have a Visiting Nurses Association, and including the urgent care. So all of that, the one PFAC supports the whole system.
Okay. And another question about whether PFAC members bring ideas to you and whether you have the infrastructure to carry through on their ideas for change and improvement.
So they do bring ideas to us. In our agenda, there's actually an idea link. So every time we send out the agenda, they have the opportunity to send in ideas. I'm in constant contact with a lot of our PFAC members, so I think we tend to talk a lot about what's going on. And through this current process that we're doing one-to-ones, where they get to meet subject matter experts across the system, we also get to learn what they're interested in and what some of their ideas are. So, you know, I have a team in my department there's 5 of us. So, you know, using that team as well, we do try to make sure that we are implementing a lot of their ideas and changes.
Great. And then do you ever do hospital or practice specific meetings?
So I will say we don't necessarily do practice specific meetings. What we do is, for instance, our MyChart. We do have a MyChart work group. So our PFAC members sit on that. We do have a revenue cycle work group, and our PFAC members do meet with the revenue cycle. So we also have the EDs. So the 3 EDs together from all 3 sites have an ED meeting that they do. So our PFAC members will be part of that. So it's not really practice or hospital specific. It's more, I guess, initiatives or projects.
Great, thank you. I see another question here that maybe I'll save till the end after all the presentations have come, because it's, I think, broader than any one specific presentation and may benefit from answers from a number of our presenters. So thank you very, very much. That was really helpful, and thanks for the questions, everyone. We'll transition now to our second presentation, and this is from Beth Israel Deaconess Medical Center. Last year, the Department of Medicine hosted a quality improvement retreat, and PFAC members were invited to attend that. One of those PFAC members in attendance was Kimberlee Perry, and she's here to talk with us today about her experience there. And she's joined by Laura Dickman, who is the program leader for patient and family engagement at BIDMC. And Laura and Kimberlee are going to do a little interview style Q&A. So no slides on the screen, and the two of you, I will let you take it from here.
Thank you so much, Emmy. So I'm delighted to be here with all of you, and particularly with Kimberlee, to be in conversation about this particular project that Kimberlee was essential for our hospital. So she and I know a lot about this project. I thought I would just kick us off by asking Kimberlee to tell the audience a little bit about the Department of Medicine Quality Improvement Retreat. And we can call it the QI retreat from here to save some time on our 15 minutes.
Yes. First of all, thank you so much for having me. I had the opportunity to be involved with the QI retreat last year. I unfortunately was not able to participate in all 5 days. So I did do one day, and I emailed a little bit back and forth with Dr. Yang afterwards as well. But basically, it was a really, really wonderful retreat that they wonderfully catered breakfast and lunch for us at Beth Israel, and we were able to kind of do like an interdisciplinary group participation. So I was there as like a family member and patient. I unfortunately am the patient, but then there was like a doctor, a social worker, a nurse, and we really were able to kind of sit together for that full day and just have an open dialogue of everything and how everything kind of goes in and out of the ICU. And it was very, very interesting. And it was a really wonderful experience. I wish I was able to do all 5 days, honestly. So, and thank you, Laura, for inviting me to do all of that.
It was my pleasure. And just to add a couple of details for folks.
Yes.
So this was a week-long event. Kimberlee shared that the advisors were invited to participate in all 5 days. Many of them, I think there were 3 total, couldn't do all 5 days, but were able to be in communication with the team on days that they didn't attend. And the focus of this particular retreat was on the transition from the ICU to the medical surgical floors, and thinking about how to make that a better experience for patients and families, recognizing that critical illness is often an experience that can cause trauma to patients and their families. And we wanted to think about how could we minimize that trauma in the transition. And so folks like Kimberlee were essential to the process, because we can't understand how to approach a problem unless we're all everybody's at the table who's impacted by it. So with that in mind, Kimberlee, do you want to say a little bit more about how advisors were integrated into this retreat, what the sort of structure was?
Yeah, absolutely. So the goal was to definitely like immerse the advisors and to fully understand the purpose and the format that we were participating in and how this kind of, I guess, exercise or retreat would go. So Laura and Dr. Julius Yang and Nishi were, who also, she's an organizer, the product organizer, correct? They were able to coordinate and we were able to do a Zoom meeting prior to this retreat. And basically it was how you can do design thinking and apply it to healthcare, and really break down the walls between patients and the medical and all the other departments. So how to implement a change in the chain reaction of in and out of the ICU. To be quite honest, before I was actually like immersed in the retreat, I kind of understood like what we were doing, and I was, as Laura knows, all in. I'm a very visual person, so until I was immersed and visualized all the slides and everything is really when I was like, oh my God, design thinking actually does work for healthcare. Like, this is pretty amazing. So come up with an idea, apply it, try it, make the changes as you need to go. You can always go back, which is kind of the way that Dr. Yang had applied it. And it was very, very interesting. So we were all able to interact and exchange our notes with that.
Thank you. So you touched on the piece about having an orientation before coming into the meeting, and then I'll add that there was also a debriefing with the 3 advisors at the end with the physician leader, Dr. Yang, to get any additional feedback on the experience, on the content, other thoughts that folks wanted to add. But I wonder, Kimberlee, did you feel like while you were sitting in the room with the sort of interdisciplinary team, did you feel like your input was valued?
Oh, absolutely. I truly did. I was able to, you know, have one-on-one time with some of them as well. I do personally feel that like a lot of our feelings and concerns are heard and documented. I know that a lot of people tend to, I always say, get like white coat syndrome around like professionals and stuff. In my experience, I always feel validated and heard, which is very, I guess, comforting, so to speak. I definitely feel like everything is documented. They definitely try to immerse myself, other patients into helping making positive strides. Things may not happen like immediately, or some things can be implemented, especially with design thinking. It's such like a wonderful process, really. And I think it should be applied more often. And sorry, my screen just went wonky on me. I definitely think that it should be applied, and it's very, very beneficial. We were able to come up with ideas, explain our position, our feelings, some of our perspectives, and how things could be done differently. Again, it's not going to be implemented overnight, but the doctors and professionals, such as Dr. Yang, Nishi, Laura, they put a lot of energy and time into doing these retreats. They're not going to waste their time on doing all of this hard work and just blow off patients and how we feel. Doctors and medical professionals and everybody else, they're all humans. But they really, truly got into medicine to help people. With that can come human error, as we all know, being patients. But I think if we all collectively worked together with the experience of having patients, professionals, everybody combined, we can really make wonderful strides in the healthcare world. And I think that, again, it's not always going to happen overnight. It's not always going to be implemented immediately. But I think we're heard. I've seen the changes. I've heard the changes. I think also, if I didn't see something that I really felt strongly about, I feel like I could vocalize that to either the department or to Laura, or, Laura, do you have any resources that we could really push this a little more? So
And
I think they did a
Kimberlee,
really wonderful job of making all of us feel comfortable and voiced and heard. So
sorry to interrupt you. And just to
no,
say,
you're fine.
I swear that this is all coming directly from Kimberlee, and I did not coach her on her responses.
Did not actually. I worked on this all weekend with my crazy 2-year-old.
So I'm always so heartened when I hear your reflections on the experience and feeling valued by the medical staff and feeling really a part of the team. And two things I just want to mention, and I hope it's okay to share this, but Kimberlee, one of the stories that stands out for me that you told me after the retreat was that you were sitting at a table, there was a nurse, a social worker, physician, and that the nurse sitting across from you was taking notes on everything you said. And that reinforced that experience for you. The other thing I want to
really
name,
was.
The other thing I just want to name quickly, and then I want to ask you a follow-up question. Sort of, Kimberlee is talking about this idea of design thinking, which is really about interrogating an issue from different directions and really exploring it and trying to understand the different ways people interact with it. And one of the things that I heard from the physician leaders of this project was that going into this retreat, a lot of the medical team thought when a patient is ready to be moved from the ICU to the medical surgical floors, that's a great thing. We're very excited. That means they're doing better. But what they heard in return from the patient family advisors was that that's a terrifying thing. And that transition, which may be celebrated by the medical staff who are thinking good clinical outcome, is experienced as really challenging and often has trauma involved in it for the patient family advisor. So that was a very important connection for the medical team to make by hearing from the lived experience experts like Kimberlee.
Yeah. The nurse that you were referencing, she was writing out so many notes. I was like, oh my gosh. But they all, they get so excited. They want to celebrate. They want to ring the bell that you're getting out of here. But for me, for my family members, it's not a decline in care, but you feel like it is because you're used to having a one-on-one. You're used to having a doctor all the time. You're constantly monitored. And then it's the less you need, the less they come in, which is good on the medical side. But for us, we're like, oh my God, this is terrifying. I feel like I'm flying solo.
And just to add to that, and to share with this group here for sort of conversation and thinking, one of the things that came out of this retreat was that a group of residents who were really moved by hearing this information put together some materials for ICU patients and families in our medical ICUs that talks more about that transition that they hadn't necessarily been talking about before. But Kimberlee, I want to go back to something else that you were starting to get to, which is about when change doesn't happen. And I think it's a common thing for our medical teams to and staff to be somewhat reluctant to involve patient family advisors out of fear about when we can't make things happen as patient family advisors would like to see them happen. So I would love for you to just talk for a minute about what that's like for you. Do people circle back when something,
Yeah.
doesn't actually manifest into real change, and what's important to you in these kinds of situations?
Yeah, absolutely. Also, I just want to make a note that I really loved that this retreat was in person. I think, especially being a patient, sometimes there's like that emotional disconnect. So I really liked that it was in person. It felt much more personable. I felt much more heard. You weren't just like, all right, signing out, have a good day. You really got to bond with these people. So that was definitely something I wanted to note. I can see why, like, as a medical professional, they might be hesitant to want to involve us because we don't know all sides of the hospital world, I guess, the hospital setting. But, it also keeps me more involved with the hospital, and I think that that's positive. I have a different stance on how they might perceive something. It's something I'm really proud of being a part of and discussing and being involved in it. At times it's challenging, and I think it's challenging, sometimes for doctors and nurses to hear like maybe they're, I don't want to say at fault, but this could be done better. This could be done differently. That's a challenge to hear, and it's not like a negative critique, but with challenge comes growth. And I have challenging things that I discuss about my journey that they might not have ever considered, such as it's a positive versus a negative getting out of the ICU. But yeah, I definitely can see how they would be hesitant to want to involve like non-professionals, so to speak. But back to design thinking, like even if a change is not made or it's not made immediately, it does not mean that it's not going to be considered. It doesn't mean that it's trashed. Like, I think things have phases and processes on how they'll go into effect. And as medical professionals, they'd be like, oh, a regular patient might not understand that. Let's stick to the professional side of it. But we can add some insight from our side that's like, you know what, that actually doesn't feel good as a patient. That doesn't feel like good bedside manner. Let's go back to the drawing board and see where we can realign things. So, like, does this benefit the nurses? Does it benefit the doctors, patients, case management, social workers such as yourselves? It's a very, very large facility, but I also think it's eye-opening for the patients to see how all of this has to be rolled out. They might think, oh, you can just go move a bench. Like, why is this that big of a deal? Or, you can just change this policy. And it's like, there's a lot of phases. So I think it's eye-opening for us as well. The design thinking process of this retreat, I said to Laura, I go, you ever assemble furniture from IKEA? And it's like, when you look at it, you're like, oh my God, where do I start? But when you miss a few steps, you can go back and be like, oh, on page 7, I missed step X. You can realign, fix it, and move forward again. Design thinking with the hospital world is kind of like that. So if it's not working, you can go back and see where it was failing and fix it and move forward and make it a positive experience for everybody. But yeah, and I think also you have to choose who you want to be on your PFAC department. Like, they're not just selecting anybody and everybody. They really do a wonderful job at vetting who is going to be on the department, which I think helps that they're getting, positive support. And even if it is negative, I think in a minute, even if it is a negative, we can handle it in a positive light. And navigate that together versus just throwing stones.
And Kimberlee, I thank you for bringing that up. And I want to just share with the group too, that because a big part of my role is thinking about who comes into this work. And part of our goal is to have as few barriers to participation as possible, because we really do want to be hearing from our community. And with that, we don't want people who are just coming in to tell us what's going well. And we've been so grateful to Kimberlee and all of our patient family advisors for helping us to see where we can do better. And this was one opportunity to do that. And Emmy, I'm worried that we're going to go over time because
I know
I could keep going. So maybe should I pause here?
Yeah, that'd be great. And actually, we have a question for either of you. So ongoing testing and inviting input and feedback from patients and family members after the retreat, including those experiencing the transition, and maybe asking questions about who wasn't part of the retreat. And so in terms of follow-up, does the unit keep working together with this patient and family input?
That's a great question. Can I field this one, Kimberlee?
Absolutely.
So two things I want to say. One is that for this particular retreat, in full transparency, it was very much an exploration phase of a process. And there is a desire to move to implementation, but many of you may know or have experienced an Epic rollout, which we have been doing over this last just several months now. And so in full transparency, I think that put a little bit of a pause on where to go from here, but we're holding this information, and the hope is for the ICU and medical surgical folks to work together on sort of how we think about implementing change from all of the really important information that was gathered. And then the other thing I want to mention is that we also have an ICU PFAC, which I would welcome Kimberlee to talk about, but our ICU PFAC is meeting in an ongoing way. And so there's opportunities to continue to engage with folks who have experienced this transition as they get to a phase of really thinking about how do they operationalize this kind of change.
Thank you. And
Any other question?
A question really for either one of you. Is there anything you would recommend to the rest of the group here today who is considering involving their PFAC members or other patient family representatives in a quality improvement initiative? Do you have any particular pearls of wisdom for us?
Yes, I definitely think that, like, if you're looking to get involved, do it. Like, if it's an interest of yours, try it. No one involved in these departments is going to force you to stay or commit you to a project that you're not on board with or that don't align with your views or your experiences. You know, they're not throwing projects at you just to fill that seat. As Laura knows, like, I've done quite a few of these, but they are really truly only on projects that I feel strongly about or that I feel like I have an experience in. Even though, the unpopular belief, I am not an expert. As some of the notes have said, like, she's like the patient experts. But I think I personally have taken on a lot of these projects, probably more so than other members, but I wish I could do all of them. But if they don't align with me or my life or schedule, then obviously I'm not going to do it. And I've never, ever felt pressured to do so. But I hope that all of the ones that I do, I have an impact in a positive light for them to some degree. I think that the open discussions that we have, if they're not used in one department, I hope that they're getting passed along to another department that they might be more useful for. I try and do my best to make this and other projects with PFAC and Beth Israel positive, like I was saying. But I really do. I encourage everyone to try and be as involved as they can. If they feel drawn to it, if they could feel like they could help or make improvements with any of the departments. I know some PFACs have kind of dwindled, and I know that they're trying to build them up more. And the more I've talked to nurses and other staff members and techs and all that, I think it will help bring healthcare back together like it has been in past years.
Can I just quickly go on record,
Yeah.
Kimberlee, to say that we diverge in the idea that she's not an expert, because I actually believe very strongly that Kimberlee herself is a person with great expertise from her own lived experience. I'm not going to let her say she's not. And I feel that way about our whole community. And I think the work is about really empowering our advisors to hold that identity, because we do believe through experts.
But yeah, I do. I think this day and age, especially post-COVID, for reference, I was in the ICU for COVID. We all know that it has done a number on our healthcare, on our medical team, on the people that don't maybe get enough representation, such as social work, care management teams, stuff like that. We all know that it's done a number on all of them. And if you're a patient or if you are affiliated with any of the hospitals and you get the opportunity, it's the only way to make change is to go from the inside out. So I truly feel like people should do it.
Well, terrific. Thank you both very, very much. This was really a terrific initiative to hear about. And I'm sure we could really talk about lessons learned for quite some time, I'm sure.
I know.
So what I'm going to do, there are some questions coming up in the chat that are sort of a little more general. And so I'll save those till the end. I think we'll have some time at the end for the more general, a more open general conversation.
And I do want to just say that, like, when she had mentioned, like, do you feel like we're being heard, stuff like that. I know that some things that have been brought up in meetings or suggestions that have been made, they didn't apply to our specific department. I unfortunately have had 2 family members in the ICUs at Beth Israel since, and they've been implemented in other departments in other ways, which I think is wonderful that, like, so-and-so pass it on to so-and-so, like, oh, they had a great idea about doing this, like, try that, stuff like that. So it is getting passed along. So I think that's wonderful.
Well, thank you very, very much. So what we're going to do next is, before I introduce our third presenters, and they're from Cooley Dickinson Hospital, I just wanted to take a moment to just make sure that everyone here is aware of a recent change in federal policy that really affects patients, hospitals' engagement with patients and families. The Centers for Medicare and Medicaid Services, or CMS, which is the federal agency that's responsible for reimbursements to healthcare providers for the medical care, actually, of more than 140 million Americans, so through Medicare and Medicaid. Over the last few years, they've increasingly been using financial incentives and penalties to try to drive quality and safety improvement across healthcare settings. And this summer, they published a new rule that has 5 domains around safety, and hospitals will be asked to kind of attest in each of these 5 domains what work they're doing. And I think that what I'd like to talk about just very briefly is the patient and family engagement piece, because there's direct references to PFACs. And I'm only going to spend about 5 minutes talking about it, but I honestly think we could spend the next year talking about kind of the implications of what's behind this. And I think this will be great conversations for us going forward. So we'll just consider this a little bit of a dipping our toe into the water here. So Janelle, if you could advance to the next slide. So this is domain 5, they call them domains, and this is around what hospitals should be doing for patient and family engagement. And what they're saying on the left is that hospitals should be engaged in effective and equitable work with patients and families, and that this should really be embedded in the work that hospitals do with patients and families involved in meaningful safety activities, quality improvement, and oversight. And the way in which this is further defined by CMS is by asking the hospitals to say yes or no. We are doing each of the following. So the first one is our hospital's Patient and Family Advisory Council includes patients and caregivers of patients who are diverse and representative of the patient population. We know that that's required of Massachusetts PFACs under our state guidance, and we also know that it's a challenge, but very interesting to see that the federal government would also like to see PFACs in hospitals across the country, and that those PFACs be representative of the patient population. The second is our hospital has a Patient and Family Advisory Council that ensures patient, family, caregiver, and community input to safety-related activities, including representation at board meetings, consultation on safety goal setting and metrics, and participation in safety improvement initiatives. And I think you'll hear from our next presenters a little bit about the ways in which those have manifested themselves at Cooley Dickinson, and also talk a little bit about what the future direction might look like. The third one, patients have comprehensive access to and are encouraged to view their own medical records and clinician notes via patient portals and other options, and the hospital provides support to help patients interpret information that is culturally and linguistically appropriate, as well as submit comments for potential correction to their record. And I think many of you are familiar with open notes, things along those lines. And so again, this is a CMS incentivizing hospitals to be doing this kind of work. The fourth one is incorporating patient and caregiver input on patient safety events or issues. So at your hospital, if something has gone wrong in your care or the care of someone that you're looking after when they're in the hospital, is there a way for that to be reported and recorded and followed up on? And then the final one is, I think that this is interesting and may come up in your own PFAC meetings, is that our hospital supports the presence of family and other designated persons as essential members of a care team and encourages engagement in activities such as bedside rounding, shift reporting, discharge planning, and visitation 24 hours a day as feasible. And so I think the reason to just be thinking about these things is that I think we all have in our minds what an ideal PFAC looks like, what are some ideal PFAC activities, and this is really putting some language behind and some direction behind PFAC involvement in quality and safety work. And then just one quick slide, the last slide, which I won't read through, but you'll have this because we'll share slides. It's just so that you understand the way in which this will work. CMS released this in August, and then beginning next year, hospitals will read each of those statements and say, yes, we're doing this, or no, we're not. And by 2026, that information will be published for all to see. If you're familiar at all with Hospital Compare, that's the website that it will be on. And then in fiscal year 2027, hospitals that don't report whether or not they're doing these things will see a reduction in their payment in fiscal 2027. So we can put the slides down. And as I said, we'll share these afterwards for all of you. And so I brought that up really just to frame this next presentation, because I think what's outlined in this new federal policy really will serve as a series of guideposts for PFACs in Massachusetts and nationally. And I think it'd be interesting, you may all end up with phone calls from hospitals elsewhere in the country, right? Because you've all been breaking ground by having patient family advisory councils for more than 10 years. And so I think it's a terrific opportunity for all of us to be looking at how we're involving patients and families in our safety work. So I will stop there. And again, we'll have some time for general questions at the end. And I'd like to turn it over to our friends from Cooley Dickinson. So Cynthia Suopis, who is a past co-chair of the PFAC there, and she currently serves on Cooley Dickinson's board of trustees. And she will be presenting along with Lisa Ekus, who is the PFAC co-chair now. So Cynthia and Lisa, thank you so much.
Thank you, Emmy. And wow, thank you, Southcoast. Thank you, BI, for those amazing presentations. I learned a lot. We hope to give you some things to think about too, in what we're doing at Cooley Dickinson. Cooley Dickinson is an affiliate of Mass General Brigham, so that is our parent enterprise and system. I'm currently a board of trustee member at Cooley, and I was the past co-chair, which some of the reflections in this presentation I'm going to refer to. But interestingly enough, I love being on PFAC and I love being the co-chair, but I was asked to be a member of our board, and I said, okay, but I have to stay on PFAC. So just having a PFAC member on our board and being able to relay to PFAC what's happening from a 5,000-foot viewpoint and a board perspective has been invaluable. So, Lisa, I don't know, Lisa's name seems to have gotten cut off of that slide. Oh, there she is. Yeah. And she's our current co-chair. So she'll be, we'll be dovetailing this presentation a little bit. So next slide. Just want to let you know that we do plan to talk about this quality initiative that has been in domain number 5 in CMS, and how perhaps we can position our PFACs to address that and give you some history about how we've tipped dunk our toe in that. I feel like it's a corn maze and it's not a hayride right now in trying to maneuver through this healthcare system. But just want to reflect a little bit about when I started on PFAC in 2018, we were really struggling. So we want to just talk about how we built up our PFAC, both in our hospital and our community, and then certainly talk about the patient's voice. How do we integrate the patient's voice into quality and safety initiatives? So next slide. So we're one of those tiny little hospitals, not like as big as Southcoast and BI, but you can see what we do. We have a broad breadth of services, and we also have our own VNA and hospice. We also do bariatric surgery. So we're a small community hospital in Western Mass, and to kind of position us, next slide, please. Where we are in the Commonwealth. You see us in that gold star there. So this is the western part of the state. Cooley Dickinson Hospital is in Northampton, Massachusetts. I hope if none of you have visited the western part of the state, particularly Northampton or Amherst, we're a 5-college town. So we have Smith, we have UMass Amherst, we have Hampshire College, we have Mount Holyoke, and who am I forgetting? I can't remember the fifth one. Yes, thank you very much.
You should know that, Cynthia.
Yeah, I know what's wrong. But we also have some competition to the north of us with Bay State has a hospital in Franklin Medical Center, and south of us in Bay State Health Systems, their flagship and home. And we also have Holyoke Hospital. So we're kind of situated rather uniquely in this community. But again, a shout out to the college town of Northampton. I can actually see Smith campus from where I am right now. We have a motto here: the coffee is strong, but the women are stronger. So come out and visit us in Western Mass at any point in time. Next slide, please. So this is the environment that we're working in. I think some of these features, I mentioned being 5 College, but some of these features in the environment may be familiar to you. We have transportation issues, we have food insecurity, we have opioid addiction, which I'm so thankful to hear recent statistics nationwide that seems to be decreasing a bit. We have behavioral health issues, we have houselessness, and we also have a very strongly increasing Medicare population. So that's the world that we work in. That's our environment. You probably all have pieces of this and other unique aspects. And these are all the things that we try to take into consideration when we not only recruit for PFAC members, but where PFAC members should be. Next slide. So I'm sort of taking this fast travel log from 1918 from 2018 to the present. And I don't mean to air dirty laundry or say these are all alarming things, but within that 4 or 5 year, 6 year period of time, we've had 3 chief nursing officers. We've had 3 medical staff officers. We've had 2 presidents, recruiting now for our 3rd. We integrated with MGB, which has been wonderful for us, but any of you that have been in a hospital that has a transition, you know the pain that causes as well. Boom, then COVID hits us, staffing gets impacted, and we all know about our fiscal challenges. And in our particular area, we had a lot of vacancies and turnover in our quality department. There's one PFAC member who said to me, boy, I hope I can get out of this healthcare system alive. And I thought about that for a second. And these are challenges, but they're also opportunities. And so we had to think about, certainly during COVID, what does a PFAC do during COVID? And we focused on our staff. I mean, because those were the ones that were really doing the one-on-one care to our patients, to our community. And Lisa, in a couple of minutes, will tell you about that. Next slide. Our PFAC goals, these are not the goals that we put on our annual report. These are the goals that we really keep in view every single day. First of all, visibility within our community, within our hospital, within our own PFAC. The patient voice, always thinking about where can we capture it? How can it make a difference? Where can we put it? Who's going to invite us to have it? We're always thinking about those kind of opportunities. Senior leadership, it might be a bit easier for us in a small hospital, but we were just focused on President, chief operating officers, you need to know who we are. We need to have constant contact, and we'll tell you about some of the ways of doing that as well. We also need to make sure that our PFAC has strong members who really want to do this type of work. We want to make sure that our voice is in quality and safety measures. And I'm happy to say that as being on the board of trustees, I happen to chair now our quality committee for our board. And that puts me smack dab in the middle of quality and safety. And without my PFAC background and PFAC opportunities to think about where we could be there in those discussions, that never would have happened before. So again, I'm a real advocate of having PFAC members on boards. And big thing that we want to make sure we have is meaningful experience for PFAC, our PFAC members. We need to keep them engaged. As you all know, they have other things to do, other commitments, other volunteer activities, but we want to keep a very, very strong PFAC. So we look at these goals all the time, and these are separate and distinct from individual initiatives that we have in our PFAC. Next slide talks about how we engage with leadership. It took a while, but I was knocking on a lot of doors, and fortunately in a smaller hospital, you can't hide. Leadership can't hide. But we met with leadership on several occasions, and at first it was, this is who we are, this is what we can do, but somebody advised me to say to our president, how can we help you? How can we help you with your strategic plan? We are a PFAC. Please tell us what we can do for you. We have some ideas. Please tell us how we can help you, and we can have ideas and an open conversation about how we can help each other. Strong advocate of attending at hospital events and knowing where they are and asking, hey, I heard there was a meeting, a quality meeting. Can we bring a PFAC member to that meeting? I shouldn't have said never say no when asked, because I really should have some limits. But if the president or the COO or the chief nursing officer said, hey, maybe could you PFAC people do this? It's not that we're going to say yes all the time, but I strongly encourage it. Whenever we can get our foot in the door and people can know that there is such a thing as this organization, even though we all intimately live with it, I'm not sure the average staff nurse or people in dietary or environmental services know. So any opportunity that we can have to do that. Next slide. Lisa's going to tell us a bit about how we tried to help our staff during those 2 years of just, well, I don't even want to relive them, but still at the same time have a PFAC presence. So Lisa, you want to take it away?
Sure. And we are still doing this, even though it's a couple years post-COVID. We came up with pop-up, it's kind of a unique name, pop-up appreciation events for our employees, for the staff. We do 3 specifics a year. We do a spring popsicle giveaway, combining efforts with a local small business owned operation where the whole staff is invited. All our events are throughout the whole day for one day, and they're advertised to the staff. So we give out popsicles. Valentine's Day, we work with a local Voc Tech school to make cookies, and we give out Happy Valentine's Day cookies. And also all of these are to say thank you. And because my former business was working in culinary world and cookbooks, this will be our 3rd year of, I donate about 500 cookbooks to the hospital, and everyone's invited and they get a cookbook. And what all of this does that's so cool and so beneficial is we get to meet the employees. We get to know them. We can say, how can we help you? We can educate them about PFAC. We created signage that says sponsored by PFAC. What is PFAC? So we're always letting them know and hopefully integrating efforts more often and in better ways. We also have our PFAC participate and volunteer during all National Healthcare Week. And often that involves a giant picnic. One year we did something with the 3 local chambers of commerce. So again, we connected with community. So we use these as opportunities to grow and to build. Let me just make sure I didn't miss anything. I found that doing these events and volunteering for them, and then I asked our other PFAC members, great way to learn about and meet upper management. Next slide. We do a lot of work and focus on our membership. We obviously go out into our community to have as diversified a membership as possible. We live in the lesbian capital of the world. We have Trans Health, which is a major medical organization supporting trans people. So we have and an aging population, so many vets and retired. And this is a great way to have a diverse membership with a lot of different backgrounds. We have a special relationship because of our awareness of the colleges and the use by the colleges of our hospital. Smith College is less than a mile away. What we did is we formed an alliance with, they don't have a pre-med major, but they do have a health track for people interested in going to med school. We formed an alliance with the advisor for that, and we have 1 and sometimes 2 Smith College students as participants, non-voting on our PFAC membership committee. And it's really great because we get the young perspective. They can tell us, what's of importance to them. How do we service them better with higher quality care? And it has been a really, really important alliance and relationships. Next slide. One of my goals, I've been co-chair for 2 years, and as Cynthia said, she's on the board of trustees. We make sure that wherever we can have a presence on a major hospital committee, we do. So you can see them right here: ethics, healthy community, finance, green initiatives, development, awards. Some of these are longstanding and meet regularly. Awards is more like quarterly, but we get to understand what senior leadership is and does. And I turn it off. And we can help them do in an integrated way for the community, because we're reflecting the community voice along with whatever the senior leadership needs to do and wants to do. One of the things that's really exciting for us is we have well, there are two things. I'll get to one later, but I don't think Cynthia even knows about this latest one, but the president, our acting president, just decided to create a brand new initiative, a committee to do regular connections, media information within our community. So there's always things going on, but to have a dedicated committee for that and to have PFAC be asked to join that, since we're the patient voice, is going to have a lot of impact. Next slide. How do we keep our members engaged? We create a welcoming environment. We provide a mentor to each new member so we can answer questions. We do surveys. We take stock. What works for you? Is this working? What's your interest? What kind of committees do you want? We give tours a couple times a year. We've done a lot with the lab, radiology, childbirth center. When our PFAC members understand how a department works, we take that out in our community. We also do a lot more with our VNA and hospice because we have an aging community, and that's been a very fulfilling part of the work. As I said, flexibility in where, when, how we do meetings. Most of ours are virtual. We're trying to integrate more hybrid and in-person because we've gotten that feedback. One of the most important things that we do is that at the end of every single meeting, we leave 15 minutes and we ask our members, what have you heard in the community? What have you experienced? Good, bad, indifferent. And those reflect the challenges, the problems, some of the great things, some of the big mistakes. That gets discussed and then brought back, because we have members from the from senior management on our PFAC. That gets brought back into the hospital and addressed by the appropriate departments. And we get feedback, what happened? Sometimes it's a really small thing. Sometimes it means a big overhaul. One of our members is in the infusion center regularly, and she said, hey, I was getting it at Mass General. They have warm blankets, a blanket warmer. They have different things that made her experience a lot more comfortable. We were able to bring that and get it instantly accepted into the infusion center, like within a month. It was great. So that's also why it loops back to engaging upper management. They will listen if you build that relationship. Sometimes it takes a longer time, but it's a wonderful way. And then to participate in as many hospital events. We go to our major donor events to say thank you. We go to the fundraising events that celebrate the people who run the gift shop and the coffee shop. Any way that we can touch people within the hospital, we do. Next slide. So we are the voice of our community. That's our goal. That's what we try to do. We work with our primary group organizer to work on some of the big challenges like call center, what's happening, how do people get through. We give feedback, and it's, you know, some stuff takes a year, some things to fix take a month. We do more brochures with different departments. We had a new radiological procedure. They came to PFAC to edit it. And because it was on for women in breast tests, all the women said, you forgot this, you forgot that. This is what we need. And we do our brochures in English and in Spanish. A lot of awards happen. There's a lot of employee celebration. We get involved in reviewing them, making recommendations, and showing up at the event award ceremonies. I mentioned we're working on a stronger communication to our community. Our acting chief medical officer is now regularly going on television. He's working with us to do regular social media posts out in our community. The community has to know where we are, what we do, how we can do it for them. And a lot of work, as I said, with primary practices, even though it's not in the hospital, it's under the MGB purview, and we all know it's really hard to get primary appointments. So what can we do? And we're actively communicating and working on solutions. And our new initiative, which we're really excited about, is we're calling it, it'll be a patient support advocacy program. It's one of our largest goals, and it will be to try to be mentors to patients. How can we improve their experience? How can we help them navigate? What happens if they have a family member who's dying? How do we support them? We are at about a quarter of the way through figuring this out. It's a big undertaking that we're going to go down a narrow lane, and I think it's going to make a difference in our community. Next slide, and taking it back to Cynthia.
Thank you, Lisa. And I was just trying to keep up in the chat. Do you invite leaders to attend your PFAC meetings? Yes, we do. President, board president, nursing leaders, department heads. Yes, we do. So thanks for all the questions.
We have 2 to 3 speakers at each meeting from the hospital. So we
and we try not to make it too top down. Right? When it's too top down, that's how it was when I first started our PFAC. It just has to be from the bottom up as well. So just in closing, we have this aspirational goal that domain 5 that Emmy introduced is kind of lingering. I introduced it to a few people at our organization. They're like, oh yeah, okay, whatever, never heard of that. But it's going to come. And it's here. So we just believe that an active PFAC is one that's going to inform, impact, influence, and educate on patient safety and quality. And we just want to sort of have that as our mantra as we begin to think about domain 5. Next slide. Yeah, so I just pulled this out of the New England Journal of Medicine in their Catalyst publication, and a quote from an article, Understanding What Matters to Patients. And this fellow, Dr. Pelazari, he's from Argentina, actually, and he says, when you measure outcomes, you obviously look at the clinical aspects of care, but you also need to consider the functional outcomes from the patient's point of view. Can they walk without pain? Can they play tennis? Can they go to the market? You have to see care through their eyes. And that's sort of a guiding principle for us, seeing care through the patient's eyes. Next slide. So I'm kind of a wonk in my research. So my My academic background is communication, particularly health communication. So I'm one of those qualitative researchers. God bless the quantitative world, love it. But I'm the one that does that kind of research where we have our boots on the ground. And so in trying to find out what our patient expectations were in our PFAC as patients, I conducted this discourse analysis about a year and a half ago, maybe 2 years ago now. And basically, this is a method. Think of it as similar to a focus group. Anything that you're wearing right now was probably the result of a focus group. Generally, they meet in Chicago because that's sort of the heart of the nation. But a discourse analysis takes a conversation, listens to people, transcribes it, and discovers themes. So what we did is we conducted a discourse analysis with our PFAC members, about 20 of them, and we just asked them one question: what are your expectations as a patient? And what was produced from that was a 20-page set of transcripts, okay? And then what I do is I look at those transcripts and I try to kind of tease out themes. And if anybody's interested in knowing having additional information on how to do that, I'm happy to have you contact me, and I'd love to help you with it. But on the next slide tells you what came out of our PFAC. And basically, this was our patient voice, and we says the themes were, you got to improve communication. You got to talk to me. And while you're doing that, you got to listen to me. I want to be listened to. And this is one of my favorite. You have to appreciate and acknowledge that I know my body. I mean, after all, I've been living in it longer than you. And so you just need to hear me when I say something about a pain or a symptom or how I want to function in the world. Or I just want to make it till I can see my granddaughter's wedding, whatever those elements of what means most to the patient. And please, what's going to happen next and how long is it going to take? I think about that whenever I have to go to our emergency department. Give me information on the process. Tell me what's going on. And I may accept it. I may reject it. You may think it's too much information. But we have the saying in the medical world, and I'm not a clinician, but it's something that we do in RD, and it's called commit and sit. Make sure you have a chair for the physician or the provider in the patient room, because as soon as that provider sits down, the patient feels like, I guess they're really interested in me. So some of these small, subtle things. Next slide. So this takes us into where can we step into this world of quality? And I would just encourage you to know where quality is being discussed. We have a medical staff quality committee, similar to what went on at BI in terms of the medical retreat to discuss a particular issue. And so ask to attend those meetings. Know what the patient complaint or patient feedback process is in your organization, and know how that works, and see how any member of PFAC can be involved with that. What are the primary buckets or categories that the patients are saying they're concerned about? Sure, there's food, but what else is there? Quiet at night. People don't listen to me. What are some of those concerns? Infection control people, that staff, that department can help PFAC members understand and learn about some of those really vulnerable spaces where infection lingers in hospitals. Where can we be involved with that? I took a look, I asked for our quality organization chart at an MGB level, and shout out to all my MGB sisters and brothers here. It was complex. And so understanding that and knowing who's involved with quality can be very, very helpful. And invite them to a PFAC meeting. This is just me. I like to research and read what's happening with the patient experience, with quality in the patient's voice. We do this thing at many of our meetings throughout Cooley, a safety catch. Where did an employee find something that could have turned into a minor or a major mistake? Let's celebrate those catches. And then finally, learning the quality jargon. There's so much of it. I'm still asking those kind of questions. What does this really mean? So next slide is just a list of, and in the interest of time, yeah, okay, next slide, yeah. Just a reminder that if you can get a PFAC member on your board, then definitely try to make that happen. Here's some quality resources, and perhaps Betsy Lehman can help us if they send the slide presentations or whatever. And a shout out, what you saw highlighted in red, the patient voice a pamphlet document that's in on the Betsy Lehman website is fantastic. Talking to ME about it, it's one way to really start capturing the patient voice. And then the final slide is just these are exciting times again. I think domain number 5 is going to lift PFACs to a place that we've always wanted to go, but now we're finally being recognized as a place where not only our payment system is going to acknowledge it, but I think other senior leadership and beyond will acknowledge the amazing potential of PFAC. So thank you so much. I think we have 3 minutes.
Well, yeah, Lisa and Cynthia, thank you so much. Very substantive presentation from you and really from everyone. And I'm sorry there are some really great questions in the chat that we didn't get to, but to be honest, these are, I think, really rich conversations that we can find ways to discuss going forward. So one on struggling to sustain membership, another one on this idea of 24-hour visitation policies. I think that's a really interesting area, and also the relationship between PFACs and any multi-specialty practices that are affiliated with your hospitals. So we'll take all of this feedback and more and get back to you soon with some next steps. Jackie, would you like to wrap up?
Yes. Thank you again, everyone, for participating. Thank you to the lovely presenters. Your presentation was really, really amazing. I know we didn't have a lot of time at the end for questions. If there's any additional questions that anyone attending today has for the presenters, or any you would like to connect with them and you don't have their email, I'm going to quickly put my email in the chat and you can reach out to me, and then I can sort of help connect you to any of the presenters if you have more information for them. Later this week, we're going to send you all a very brief survey just about your experience. This will help us really improve for future webinars and forums. And then we'll definitely be in touch about more upcoming webinars or more information or stuff like this. Again, thank you all so much, and we hope you have a very lovely week ahead.
Thank you, everybody.
Thank you.
Thank you all so much. Enjoy the rest of the day.